Welcome to Dead Serious. This is a show where we are unseriously serious about death, and we love to talk about everything in between. Today, I'm super excited to welcome Greg Adams. So, Greg, you've been doing this for 30 years. You're one of the most respected children's hospital in this country. And I think there's a term called death positivity, right? Before that was trending. You're really at the epicenter and also the pioneer of this movement. So this is why we're so interested in having you on. And I would love to understand just from your perspective, right? What are some of your key experiences that you've had in your career that is maybe the most common thing that families have came to you about?
Yeah, well, thank you, Crystal, and thank you for letting me be here. And if I could, I might even go back a little before professionally, because I think that for me there is some personal connection. Um, I grew up in a family where my mom was the daughter of a funeral home director, and so she lived in the residence part of a funeral home in a small town in Missouri. And I had three uncles who ran funeral homes. And I heard stories from her and in my family. And a couple things have really stayed with me and rung true over the years as I got into this profession. One was when she was a girl, she would have friends who wouldn't spend the night with her because they were in the funeral home and it was too creepy. And she said that her parents taught her that it was no reason to fear the dead. It's the living that can hurt you. And which I think really rings true, that we are fearful of death and people and all things connected to it and the dead, when actually we couldn't even tell kids sometimes that a dead body is the safest body. It's one that can't hurt us at all, despite what the movies and the scary stories say. The other is that there are things worse than dying. And my parents taught me that. I don't think they were the only parents who taught their families that. But death is a part of our life, and it's a very difficult, challenging part of our life. I don't want to pretend otherwise. I think it really is. But there are also things that are difficult when people suffer and have some preventable suffering that sometimes can be more distressful. And when people feel stuck in a limbo situation where they're not dying, but they don't feel like they're living either. And that can be a very difficult spot. And so those are some things that stayed with me as I came into being a social worker at a children's hospital and working in oncology, pediatric oncology for 10 years and working in palliative care for 9 and doing grief support and outreach and education for the last 30 plus years. And I think part of what we have seen is that, there are some people who say that we're a death denying culture here in the United States, and other people have said that we're more of a grief-denying culture than a death-denying culture. And I think there's something to that, because we talk about people dying a lot. We, in some ways, our news reports are a death report. How many people died in a bombing or in the recent heat wave or when there was a flood or, whatever the situation might be. But do we really have space for people who are facing the dying part and people who are adjusting to the death part, the grief part? And I think we really struggle with that.
Yeah, absolutely. This couldn't come at a better time, this conversation. And I can tell you're just such a kind soul. I can hear it in your voice.
Thank you.
Thank you. Your credential, from licensed clinical social worker as a starting point, your fellow in ontology, and work really is buried in science of death, the dying imburement, and having 30 years at the Arkansas Children's Hospital. You must have seen so much. And I love to dive a little bit deeper exactly on what you're saying, because there's this in between, right? My grandmother, who was just transferred back from the hospital to in-home hospice, she's sort of in this in between right now. She has refused to eat for the past 7 days. There's been a bite here and there, but we were told that this really is a sign of dying or active dying. And we had no idea, right? And if we had known this a month ago when she initially had that stroke, our entire purpose would have been trying to make her comfortable or, seeing what we can do. But we went through the hands of several doctors, and none of the doctors share that information with us either. So I think it's also lack of education, where maybe even the doctor's refusal to share tough information, even though maybe they knew. Finally, there was one doctor that told us last week that, hey, refusal to eat is a sign of active dying. And so we could have saved that month because during that month, we kind of, we were trying to speedy recovery. Right. And this is the part where I love to talk to you or ask you more about from a doctor and, a clinical perspective, how do you see kind of the dynamic between the family's education or lack of understanding, the doctor's information relay to how that translates ultimately back to the patient themselves or the dying?
Yeah, that's a great point, and what a difficult time for you and your family as trying to navigate what you're seeing and what your grandmother is experiencing. I think that in some ways we often find ourselves in a conspiracy of silence where families don't are afraid to ask or don't have the confidence to ask, and it's hard to ask because they're also afraid of what the answers might be, and doctors sometimes are reluctant to go there and to explain or to help people explore what their concerns and their are at the time. And so then we end up not understanding what's right in front of our face. And we see that in a bigger picture where, many surveys have shown that most people in the United States want, if they had a choice, they would rather die at home. But
Mm,
most people die in a hospital or a nursing home or somewhere else. And I think part of the reason for that is that people don't always know that they're dying. And we don't always know that either. And part of that's because we can do so many things medically that sometimes it's hard to know when it's happening.
I see.
But sometimes it is happening, and we need to have those conversations early on about what the chances are for survival or not. Because I think, in my experience, that when anybody in our family has a medical crisis, ourselves or somebody else, I think we have two questions that we struggle with, and the healthcare team really needs to help people with these questions, even if they don't ask them.
Right.
They need to help bring it up. One is, are they going to be okay? That's the question everybody asks, right? If you got a call today and somebody's in a bad accident or had a bad medical event, you say, are they okay? And part of what we mean is, are they going to survive? And then the other part is, are they going to be back to normal? They're going to be back to, their baseline where they were. And so I think that we as a healthcare people, we need to help people understand those two questions as best we can, when there's a healthcare crisis. So what's the chance it affects somebody's survival and their chance of recovery, being back to the person that they were before and the level of health they had before. And then continue to keep that door open because that there's things could change
Yeah.
and and things could go better than we think. And so now we're out of the woods and we think, there's a real threat in the beginning, or things could change in a way that the threat is harder and somebody is more likely to die. And then the other question that people have is why.
Mm,
And it's kind of a two-part question, I think. Part of it's how. How did this happen? How did the accident happen? How did somebody get this disease? What's happened in the body? And sometimes we can answer that, and we need to try to answer that to help people understand the how. And then there's a bigger, more spiritual question about why. Why did this happen to my person? Why did it happen now? Why my family?
mm.
And we, for the most part, we can't answer that because those are bigger questions and everybody has to wrestle with that on their own. But it's our job to be with people and help answer those questions and support them as they wrestle with those. Because it doesn't have to be, it's scary enough when we talk about it, but it's scarier if we make it unspeakable.
That's so profound. I love the way that you brought in, the spirituality of it, the clinical side of it, and then, the dynamic part of it as well. I love to walk through the unpredictability of it all and just kind of peel that back. If I were a family member coming to you as a doctor or coming to anyone at wherever they are, it might be hospital, it might be, senior care, assisted living. If there is a sudden decline, and I feel like oftentimes it's a state of panic because that also happened with my other grandmother where she had a septic infection and within a week we lost her. And there
Mm,
was just a lot of chaos, a lot of confusion, a lot of panic.
hmm
And the doctor was trying, but we weren't really sure what was going on. And suddenly the decline just felt exponential. And one day she just didn't open up her eyes. And, as a family, how should we ask these questions? Just because someone is in hospice doesn't mean they're going to be in hospice for 2 weeks. They can recover. How do we navigate just that beginning part?
Yeah. There's a book came out a number of years ago called Handbook for Mortals, and it had suggested two questions in there that I have found helpful. I found helpful in my personal work when my mother had cancer that was incurable and eventually died. And and she gave me permission to talk to her doctor, so we didn't live in the same state. And every now and then I would say, "Mom, I think I need to talk to your doctors." And she'd say, "I think that's a good idea. Would you tell me what they say?" Because she had a hard time asking questions
Huh.
and having that conversation. And I don't think she's alone in that. But the two questions that were helpful to me that came from this book that I made use of, one is to say, ask the doctors, and this kind of thing can help physicians know what you want, as they're also trying to be humane and not distress people unnecessarily. But one question is, so realistically, what is the best that we could expect? What's a, in this situation? And you want that realistic thing, you're given, that's an important word.
Yeah.
And and then the other question is realistically, what's the worst that could happen? And so for me, that kind of a question helps give me some bookends, but what we're dealing with. And because then we can try to make a decision, because we would make a different decision about things if we think, oh, this is something that we can get out of. We can get some antibiotics, we can do some treatments, and then we think we're going to be able to survive and get back to living,
Yeah.
as opposed to this is a situation that is unlikely that that's going to happen. And we're looking for people's best guesses because nobody knows for sure, even the really experienced people. But that's what we want. We want their best guesses. And I used to work with families, particularly in the palliative care world, and they would say and parents would say something like this about their kids. They'd say, it's okay to go to the ICU and go on the ventilator if we're going to get off and get to come back home. But I don't want to get stuck there and never get off and be stuck in the hospital for the rest of their life. And we couldn't always know that, but that was such an understandable concern. They were trying to figure out, where are we on the map? Are we toward the end? Because that's a different decision making than this is a dip in the road and we're going to get back to where we were. And I think it's our job to help people understand where they are on the map. And it's our job as family members and patients sometimes, if we're not getting those answers, to try to ask those questions so we can make a better decision.
I love the way that you just said that. Absolutely. And I think every family has a different intention, right? There are family who's potentially made peace and said, we just want to make this person comfortable, or we're going to try whatever it takes. And sometimes I have seen cases where patients' own desires are potentially put on pause because the family's desire sort of trumps, we how can one navigate that complex dynamic?
Yeah, that's a great point. And I have a few thoughts there. One is that, there's different ways, I think, to live and die with dignity. And some people want to go down swinging. If they're not going to go down. They're not going to go gentle into that good night, right? They're going to say, I'm going to fight for every day and everything. And that's the way they have made it this far in their life. And that's the way they want to do that. And I
Yeah.
think that's hard for some of the rest of us to watch sometimes. But I think that is something that we can support. We have to be ethical. We don't want to give people things that are going to cause them more harm than good. That's not the right thing to do. But if people want to push and fight, and they understand what the situation is, that's our job, is make sure they're not doing that with a false understanding of the situation. They say, okay, I know the odds are poor and all, but I want to do the best I can and hope I'm the 1 in 10,000 that survives this. That's people's right to do. And I think we try to find a way to support them.
Mm.
And and then some people will say, it's no, if I don't want to fight for that. I want to just try to have the best days I can and the best time that I can. And then we try to support that too. And then sometimes, as you mentioned, people get caught with their family because they might get to the place where they feel like, okay, it's time for me to rest. And this is not a battle worth doing. I'm not going to win this, but I can, if I quit using all my energy to fight something, I might be able to have more pleasure, enjoyment, fulfillment in the time that I have. And then other people say, no, you can't. You got to keep on pushing. And then sometimes it's up to that person to decide.
Mhm.
And it's interesting, I think, to think about it that, we value people and we honor people sometimes who sacrifice for others. The firefighter who rushes into the building and puts their life on the line for other people, we honor them and that sacrifice they made, to sacrifice their own safety and welfare for the good of others. And I think that sometimes that's what patients do too. They say, well, this is not the decision I would make, but if it's going to help my family, I would make it. And that's going to be hard to watch, but I think sometimes we need to honor and respect that too, that they are trying to do it for their family. It's hard to see somebody pressured to do something that they don't really want to do. But in the end, they should get a choice about how they want to live their life and what's most important to them.
Absolutely.
I think that I would probably be that way. I would have to wrestle with that. If I had an incurable situation and or what it looked like that way, and my family and my kids and my wife said, we need you to keep on pushing. I'd have to give it some thought. Am I
Yeah.
going to do that for them?
Yeah.
Or am I going to say, you need to understand and I want you to support me with this? And I don't know where I would come down on it, but I would have to think about it really hard.
Months.
Hmm.
And the energetic pull of that, I'm curious if that's something that you've seen, right? So if your family has asked you to push a little harder and try a little harder, have you seen that turned around because there's a will in there or a lack of will?
I think that's a delicate thing because I think that sometimes we put too much pressure on people and we say, that you could fight this and beat it, and it's a matter of believing or hoping or fighting. The reality is, that all of us will die. And it doesn't matter how much we believe and hope and fight it. There will come a time that it is too much. And I'm reminded of, John McCain, was diagnosed with a brain tumor that was an incurable brain tumor and I've had several friends die with that tumor and I've seen patients die with that tumor. And I remember that the news reports were, if anybody can beat it, John McCain could beat it. And it frankly, it kind of made me mad. It's like, you shouldn't put that on somebody. It doesn't matter how, there are some situations that it doesn't matter how strong you are or how much you fight or hope or how much strong your faith is, that we will eventually die. And this is one of those situations. And they did a study in the palliative care world a number of years ago with lung cancer patients, and that all had metastatic lung cancer and they all died. But on one group, they gave them the typical chemotherapy, and the other group, they gave them the typical chemotherapy plus palliative care. And so they really in the palliative care part, they really focused on their suffering and on their distress and tried to help them with that. And what they found was that even though all the patients in the study died, the people who got palliative care, they lived longer.
Interesting.
And I think when we think about it, it makes some sense that if you have less suffering, then you
Huh.
might want to live longer, or you might have the will and the energy, motivation to live longer because your suffering is being attended to. And we are helping people with their anxiety and their physical suffering. And I think that that's part of when we make things more open to talk about it and where we can be more honest about this is our situation and how can we make the best of it, no matter what the outcome is, we can actually help people, I think, sometimes live not only better, but longer because they want to live longer and they have more energy and it's more to live for.
Yes, absolutely. I'm glad you brought this up as well because, you are truly the authority who's seen everything. I would love for your 30,000 point of view and diagnosis on the industry, right? We're talking about palliative care, we're talking about hospitals, we're talking about doctors and doctors' own experience with families and then families' own dynamic. What is your perspective of what the most challenging thing is on this overall industry? And what do you think is going really well?
I think on the positive side, and this has been part of the hospice movement, it started back in the 60s and on, is that we have tried to bring more honesty and transparency and compassion to people at the end of their life and to say that we should not treat it as an add-on, as an exception to the rule. This is a part of the deal. This is the part that everybody's going to experience. Most people, not everybody, some people die unexpectedly, but most deaths, particularly in the United States and a lot of developed countries, they die from people who have consequences of chronic illnesses. And
Yeah.
we see that. And so let's try to make that experience as good as it can be. Let's honor people, give them dignity all the way to the end, and honor the value of their life, even though it doesn't look like it used to. And I think that's been a real positive thing. And I think that the palliative care movement has followed the hospice movement in that let's try to minimize preventable suffering, even when we can't change the ultimate outcome. That's a worthwhile thing to do. We haven't followed along sometimes with the kind of resources and research we need to help with that. There's so much of the time it's all about cure and it's not about living well. And so I think we're needing to balance that. And one thing that happened that was positive, but it shows us the positive side, but also I think how far we have to go. So in the Affordable Care Act, sometimes people call Obamacare, one of the little known benefits in that act was it changed hospice for children. So they have a thing called it's called the concurrent hospice benefit. So in the past, what would happen is that when kids, like adults, when they got to the place where they had a 6 month or less life expectancy, which is how you qualify for hospice, you have to have a doctor say you have a 6 months or less life expectancy. Even though sometimes, like you mentioned, people like Jimmy Carter, they live longer, but then they can be recertified because, the basic condition hasn't changed. They've just done better than we thought because we're not perfect at predicting. But if you get in that fork of the road, if you choose the hospice path, that means you can't do any more life-prolonging treatment or potentially life-prolonging treatment. So, for instance, in the cancer world, you can't try that new experimental drug that might have some benefit, and it's not because the hospice people are being mean. It's just their payment system does not pay for that. They can't afford to do it, to provide that, because they get paid per day. They don't get paid per treatment. And so it really put a lot of people in a bad spot where they might be open to hospice, but they didn't want to shut the door on maybe something that could lengthen their life. So here in Arkansas, in our program, before that hospice benefit, our palliative care program, we were following, at any given day, we'd have 5 or 6 kids getting on hospice that we were following, with our palliative care program. And now, because families don't have to choose, when they say yes to hospice, they still have access to everything else.
Wow.
We have 25 to 30 kids on hospice on any given day because they don't have to choose one or the other. Some of the kids we had got in-home nursing and because of their care needs, and they were on a ventilator. But if they would have said yes to hospice in the old system, they would have lost their in-home nursing.
Wow. Can you tell me more about this program?
And so the hospice part would mean, okay, we know we're probably in the last chapter, so let's go ahead and get some extra support at home. But if something comes up, I might want to do something. And it doesn't have to be an either or. I think what people have learned is that people who, when they've tried this, even with adults, that people use the emergency room less, they're in ICU less.
Yeah.
So it actually can help save the system money because people get more comfortable being at home, but they still have the option. And having the option is really big. Most of us, want to have some choices. And so I hope that we can eventually get to that place where we can not have to make it an either or thing, because most people, that's what we want. That's how I describe palliative care, is that it's trying to help life be as long as it can be and as good as it can be, and trying to find the right balance between those two things. And sometimes they work well together and sometimes they're in tension, but we're trying to find for this particular person and family what the right balance is between those two goals. Because we want a long life and a good life. Most of us don't want a long life and a bad life.
Yeah.
You know.
Key term that you just said is having the option is huge for families. And we talked about resources. We talked about the lack of resources. When we were building Renity, I made it a goal for us to have a directory of all the nonprofits, all of the resources that are available, right? The death doulas that are on site, the
Mhm.
hospice that's there. Let's get the ratings in, get the funeral homes. But the problem, I think, is that there's actually a lot of options, but it's the fact that families don't know. There is this whole cloud of options, but they just don't know how to tap into it. And then another issue is that if they do know it's available, they don't know how to get the right match that's for them. And so I'm curious to hear what your thoughts are on, just as an expansion to this thing that I've witnessed myself, and how can that be improved?
So one thought I'd have is, a couple generations ago, we in the healthcare world, we had a very much more of a paternalistic perspective. We told people what they were going to do, and we didn't even tell people sometimes what their diagnosis was. A couple generations ago, people didn't always know, and we have moved away from that appropriately. That's not ethical, and it's not humane and compassionate to leave people in the dark like that. But some people would say we have swung the other way to where we're much more of a consumer thing of model, which is, do you want treatment A, B, or C? We'll do whatever you want, or people come into it. And there's some real drawbacks to that too, because then you have people trying to make decisions on their own and not being guided by somebody's expertise. And I think that there's an appropriate middle ground where we have this in the healthcare world where we talk about shared decision making, where we try to have conversations with people about what their goals are and their priorities and their concerns are. And then based on this, what they bring, then we can say, this is what we have possible. And then we try to put them together based on what's really important to you and based on what we have that's available to try. Let's make a recommendation. And I would recommend that we go do this. And then if that's not okay for the patient or the family, then we talk about it some more.
Yeah.
But it's a way that we try to make decisions together. Sometimes I think about it in terms of if you were going to go buy a car and you go and you have a good salesperson and you get to the car lot, what are the first thing they're going to ask you? They're going to say, what are you looking for today? And if you say, well, I need something to pull the boat on the weekend, then they're not going to show you the Toyota Corolla because that doesn't meet your needs. And if you say, I need something, I have a 45-minute commute every day. I want something that's really going to be good on the gas, and they're not going to show you the Suburban or the big SUV. They're going to find out first what is important to you, what do you need, and then they're going to tell you this is what we have that might fit your needs. And if they're really good, they might even say, we don't have what you're looking for. The person down the street might. I think they do. And so because we try to match up what's available with what somebody's needs are. And I think that that's in a crude way what we need to do more in healthcare, which means we need to have the conversation to find out what's really important to somebody. And then we need to let them know what's available and what it might be able, how it could help them or not. And then we need to try to find a way to blend those things together, which means we have to help people. We need to have better conversations in order to do that.
Absolutely. So opening up the conversation and, as you're saying this and kind of, explaining, I can hear you're such a patient person. And I truly hope that the hospital, the medical system is Greg Adams times 100.
Well,
And
you're very kind.
and I mean it, right? And I've experienced a lot of times personally with my grandparents that wasn't the case. Like we couldn't even chase down a
Hmm.
doctor to just check on the basic things, right? We were always pushed for the nurse. The nurse is overwhelmed, the doctor's overwhelmed. It's not to say that they don't come from a good place. It's simply stretched thin. So in that event, how can a family navigate that? I'm just trying to push for the scenarios that potentially is a reality, in a system that potentially isn't serving them in the way that a Greg Adams hospital might.
Yeah. Well, I do think that's the encouraging piece to me about the growth of palliative care programs, because when palliative care works well, that's what it's helping people do. I've heard a palliative care team make a presentation. I thought it was really insightfully said. They said, our intervention is not any treatment or drug. It is a conversation. That is our major intervention, is to have a conversation. I remember on a personal level, my mother-in-law had been in the hospital a few times, and the recommendation was her to go back to rehab. So she's in her 80s and she's losing strength, and she has congestive heart failure, and she doesn't want to go back to rehab. And then one of the healthcare people were kind of trying to guilt her and scare her, like, what if you fall down and you can't get up? And it really, frankly, made me mad. It's like, that's not the important part. There needs to be a conversation. Why is it you don't want to go back to rehab? And what do you want to do with your time? And eventually they got in a compassionate palliative care physician who sat down and had a long conversation with her to find out what was important to her and to try to help her understand what realistically medicine could offer. And they came up with a plan.
Okay. So in this case, is there a third party person that, a family can access to instead of accepting their fate with whoever their current situation is?
Well, that many places, not all, but many places, again, if they have a good one, there's a palliative care consult and they can ask for that. It's their right to say, I would like to talk to your palliative care team. If they say we don't have one, then I would say, well, how can I talk to somebody who this is their thing? There's a Center for the Advancement of Palliative Care, and I think the website is Get Palliative, but they would have information. And that, of course, that's not the only thing, but I think it's a huge thing because people who this is their job and they've been trained, and if they do it well, they've been trained to ask the questions and to listen and to help people sort through options and what's possible and help them see what might be possible, what's not, and and they have what we call goal-directed conversations as opposed to procedure-directed conversations, and where we try to find out what's important to people and their hopes and their fears, and we try to then match up what we can provide to them. My experience in the healthcare world is that we are trying to do better in training clinicians for that, doctors and others, but having how to have those conversations. We still have a long way to go, but we're recognizing that we've got to do better. And so we're trying to work with that. And I want to come back, Crystal, just for a second about your situation, because I really feel for what you mentioned earlier about your grandmother and the eating, because I think I've seen that before too. It's such a difficult thing because the way that we show care and appropriate nurturing to the people we love in our family from the time that they were born is that we feed them and we make sure that they're fed. And that's how we show love and nurture and care. And so when the body starts shutting down in the process of dying, then people are not hungry anymore and they don't want to eat. Or they might want to eat, but they try and they just feel like they can't. I remember my mother on hospice, she'd say, bring me a little bit, make me a plate. And she would, part of her wanted to, and then she would just couldn't. Her body, it would have made her more uncomfortable and increased her suffering to eat than not. And it's not like you or me. Like if I'd go for a day or two without eating, I'm suffering, because I want to eat. My body is not dying. And it says, give me some food. But the body that's dying is different. And it doesn't have the same need and is not suffering when it's not doing that. It's doing its job and the work of shutting down. And we need to help families understand that and then deal with that distress of, but this is something I can do is I can help them eat and to know that contrary to every other experience in their life, this is actually not the way we help and we show care. It's to pressure people to eat when they don't, when it doesn't make them feel good and when their body doesn't need it.
Yes. And I'm just kind of thinking back as well, a month ago when the stroke initially happened, she was in good health, making
Hmm.
dinner, gossiping on the phone with her sisters. And after the stroke happened, that's when everything took a turn. I also spoke to other people who was trying to navigate what do we do now is such a big question
Hmm.
that, people Google. People don't know when someone dies. People don't know towards end of life, during mourning, all of that. What do I do? Right. And so taking myself back a month ago, our first phone call was to the hospital, right? Like we took her in, it was an emergency. Hospital didn't want to discharge her to assisted living. But again, the family, like our side, was pressuring the hospital to do that. And then we ended up transferring her to assisted living. And then from there, we were introducing physical therapy. And
Hmm.
that's where we started seeing her stop eating or eating very little. And then we took her home because that was her request. And she stopped eating even more. Then we got her back to hospital. Then we transferred her into hospice. Before, we just didn't know that she was actively dying. And
Right.
so you can see her poor body in the past month has been transferred between hospitals, assisted care living, hospice transfer back home so many times. And how can this chaos be avoided?
Part of what a good palliative care people do is they try to provide the continuity,
Yeah. And where do you
because
define this palliative care, in our case?
yeah, so the question would be at that hospital, did they have anybody, did they have a program to see? Because you need a home team in some ways in this situation to look at everything. Because the way our healthcare system is often set up is we are better at a crisis. We know what to do in a crisis to bring in, we're going to full court press, let's hit everything we can to
Crisis.
stabilize somebody and keep them alive. And that's really great in so many situations. We want that. And our healthcare system, we divide people into body systems. And so we have somebody look at the neurology and we look at the kidneys and we look at the heart and they look at the breathing. But what are we looking at? The whole person. I had a friend of mine, she took her mother to the doctor and the doctor said, well, my organ system is doing fine. And the adult daughter was like, yeah, but my mother is not doing fine.
Yeah.
So she needed somebody to look at the whole person.
Right. Right.
And so that's part of, I think, the corrective we need in healthcare in general is we need to think about the whole person and how it's all working together. And I think that in sympathy to your family situation and your grandmother, I wonder about, trying to figure out, again, if we kind of look at that idea about where you are on the map. In the beginning, we thought this was a setback, but it was not the end. And so there's a different set of priorities when it's a setback. We do rehab and we do all kinds of things because we want to get somebody back to the best they can be so they can continue to live for a long time. But if it's that we're really at toward the end, and there can be that, I think, that gray zone where you really need somebody to help you sort it out and think, where that, are we in a different place? Are we really moving toward the last chapter and even the last, we're not talking months and years now, we're talking weeks and months.
Yeah.
And then there's a different kind of priority decision making if we're talking weeks and months than if we're talking months and years.
Yeah. It sounds like the key is in the palliative care consultation and just understanding from this touch point where everything can kind of go. And yeah, let's move on to the next stage of end of life, if you will, right? Like when a family loses someone tomorrow morning at 6 a.m., there's no plan, no clue. Who do they call first? What I'm trying to do is really map out that first touch channel from hospital or pastor, church, or funeral home to Google.
Right, right. Well, it depends, of course, on a lot on where. If you die in an institution or with the healthcare people, then your next step is they're going to want to know under appropriately. What should we do with this body? Because people have different choices.
Right.
And then if they're at home and we didn't anticipate it, then we're going to have to figure that question out too. But there may have to be somebody else coming, to do the official pronouncement of this is what happened, and to make sure that there was nothing irresponsible that happened, because we want to be careful with that. And so sometimes you end up having to have a coroner or law enforcement people involved. Unless there's an urgency that comes from your culture, which says because some cultures and religious traditions might say that it's important to bury the body within a particular time period. Unless you're coming from that kind of a culture, one thing is that we have time and we don't have to make quick decisions. Even, a funeral home, they can hold a body and there's not a time period where it says we have to make a decision in the next 24 or 48 hours about what we're going to do. We can take some time to get the people that are important to us to help us make decisions, which might be family, which might be our religious leaders, to sit down and sort through what is best for us at this point and know that it's not an emergency now, because the emergency in some ways has passed for that person. And we can take the whatever time that we need, in order to figure out what makes sense for us in the next steps.
I love what you just said. We have time, right? Because the first thing I think the feeling is almost relief, right? It's like, okay, this person isn't suffering anymore. The chaos, the panic, the
Hmm.
emergency is now drawing to a conclusion. And it's not relief in a sense where you're happy that this person passed. No, it's a relief that on both sides, right, of the equation. And
Hmm.
having that time back to yourself, what happens in that handoff? How long can a hospital allow for you to sit there, or hospice and all of these different facilities if it's not at home?
If they were interested in talking about, would it help you to know what's going to happen? If they said yes, then we would talk it through. And we would say, when it appears, that they have taken their last breath and their heart stopped, then a doctor will come and to listen to confirm that. And they will then do what they call a pronouncement and say this person has died, and they will have a time. And then at that point, we are not, unlike everything else we've been doing in the hospital, where there has been an urgency to take care of problems. At that point, we don't have urgency, and we can, in our place, we would say we can often clean up and dress a body, and we would offer that to the family if they want a family member to be part of that. Some people, that is not what they are comfortable with, and that's not helpful. And so we would do it. And then if people wanted to, and most of the time people did, and I found that it was helpful for them, is that they would return into the room and spend some time with that body after it was unhooked of everything else and it was cleaned up and dressed. And the last moments may not have been peaceful at all, but this was a more peaceful image and experience. It generally helped. The family could stay until the funeral home people came, but for most people, it was easier for them to leave than to watch a body be taken away. And so then they would leave. They would pack their things and leave. And when I worked in the cancer world, and we would often tell people, we will leave this child in the room until the funeral people come. So they're here close to people who know them and love them, as opposed to being in the morgue. In our hospital, we didn't have funeral people come to to the units where the patients were, but we would meet them at a loading area. And so then when they would come, we would go down and meet them and take the body there. So they would go from one group of people who were watching over them to another group of caring people who were going to take care of them from the next point. And that was often comforting, I think, to families to know that
The care continues.
that's right. And
Yeah.
it's it's true in some ways, when a body has died that they're not suffering anymore, not experiencing anything else. But it takes time for us to make that adjustment in our head. And we still want a body to be treated with dignity. And it can give us comfort to know that somebody's caringly taking care of somebody that was so precious, to us. And then, but if the family didn't know what they wanted to do, we could hold the body at our hospital and in the morgue for even a few days, and or the funeral home could have that body there for days, while the family decides what's the best thing. Do they want a burial? Do they want a cremation? Do they want a funeral before cremation? There's a lot of decisions that eventually need to be made, but they don't have to be made the next day. The family, if it helps them, they can do that, or they can help to meet with people and find out what their options are, and then think about it and talk about it and sleep on it and come back. So they don't have to make a decision so soon. And I see that even in the grief support world, sometimes people feel like they have to, for their kids or for their loved one, they got to have them see a therapist, very soon. Most of the time, that's not true. Even if seeing a counselor or a therapist is a good idea for that person, most of the time you have time to see how somebody adjusts and if somebody needs it or not. And if that's appropriate, you don't have to make a decision fast. But we have a hard time not doing stuff. We as people, we want to help, and we equate helping with doing, and sometimes doing is not the best thing, and that's hard. There's that old saying, don't just sit there, do something. And in the end of life world and the grief world, we flip it. And sometimes we say, don't just do something, sit there. And because sometimes just being with it is the appropriate thing.
I'm like, I'm getting teary just listening to you, speak about this. And I can't imagine how many children, families, and have kind of gone through under your wing. And I'm so happy for them to have experienced you as their doctor or caregiver. What a privilege, because that dignified way of dying under your wing. And I can just hear it from your voice how much you want to help. And that's just so touching. So thank you so much for dedicating your life towards this cause. And I know that you're also dedicating a lot of your time, right, since 2004 in the morning news, which I love to talk a little bit more about the grieving side and just dialing back into this decision, right? You mentioned the word decision several times, and I'm curious, when does that decision happen? You offer the question, which is, would you like to know what to do next? But from a family's perspective, when does that happen? Do they make a decision after death? We're like, okay, we know now for sure. Walk me through the timeline.
Yeah. Yeah, that's a great question, and it differs so much because of the context. Most deaths in a hospital, at least my experience anyway, at a children's hospital where I work, most deaths we anticipate because we can see it coming. And sometimes we even make some decisions toward the end because we may say we need to change to what we would call a comfort care status where comfort becomes a number one priority as opposed to life prolonging efforts. And so those situations, we need to rethink everything. Do we need to take these labs anymore? Do we need to give them the same kind of medications? Do we need to continue the, feeding and nutrition? And sometimes yes, sometimes no. But we need to rethink everything in the context that we're in a different place than we were before. And then sometimes we know that somebody is very sick, and so we wouldn't be surprised if they didn't survive this situation. And then there are the other times, and this happens less often in the hospital, where it catches everybody off guard. Most often that happens in the emergency department, where when somebody comes and they've had a terrible accident or terrible something has happened. And then we are trying at that point to do everything we can because we don't know otherwise, to try to see if can we save this person's life and help them live and have a good life, going on. So it ends up being different in every situation about how much we're anticipating, how much the risk is there, how what kind of conversations we can have, what kind of conversations a family is open to, because we need to do the best we can do. And then some people are much more willing to have a conversation. Some people are like, I'm not talking about that. We're going to keep on. And they're going to go down swinging. So they don't want to even entertain the idea that this might not work. And that's their choice. As long as our job is to make sure that we have done the best we can to help them understand the situation in the best way we know it to be. That, if they say, I hope somebody survives, and we say, we hope so too, this is looking really difficult, and there's a there's a real chance they may not survive. Is it possible we could talk about if that ends up being the experience, about how we want it to go, or
Yeah.
what would be important to you if that ends up being the path? We're hoping it's not the path, but if it is, what kind of things would be important? And a lot of people, if we can respectfully do that, have that conversation, they will go there with us. Not everybody, but a lot of people will.
What would you say, like, how would you summarize the number one question that families do ask you
I do think that survival question is one of the biggest things that they're going to have. But I think the
first?
question that they often don't say out loud, but they're wondering and it's wrestling with, it's what does it mean to be a good person in this situation? So in the
Mm,
pediatric world, I want to be a good parent. What's it mean to be a good mom or dad in this situation? But it could be, we also have some adult patients in our hospital. We have a burn treatment center that has adult patients. And so it could be from the spouse or the adult children. What does it mean to be faithful and merciful and caring to this person? And sometimes it means pushing, for every possibility for them to survive. And sometimes it means supporting them to not put them through things that are not going to be helpful. But I think that's a fear that loving people have, is I want to be able to look back and know that I did the right thing,
yes.
and not feel unnecessarily guilty that I didn't try hard enough or that I put them through too much. And I think that fear of failing as a family member, I think is a question that people wrestle with all the time.
Right, like what the technical term is, that you don't wanna fail the dying. It's called
Yeah.
anticipatory grief or survivor's guilt.
Yeah. Sometimes I wonder, Crystal, if it's many of us get out of these situations without having wrestling with some questions of guilt, and putting ourselves on trial.
Yeah,
Could I have done better? And sometimes I wonder if it's kind of just choosing which kind of guilt I'm going to wrestle with. Am I going to choose with the guilt of that I didn't try hard enough and didn't explore all the options? Or am I going to wrestle with the guilt that I might have pushed them too hard and put them through too much? And,
yeah,
I don't know if we can totally avoid those questions,
yes.
but we want to do the best we can.
I'd love for us to maybe even have a second episode and just talk about grief, because mourning, grief, and the anticipation of it, and the whole dynamic of the living guilt, right? Plus the dying and honoring them, and then the post death element, which is the other. So, to me, there are four stages of end of life, in my opinion. There's the pre planning, when you're just
Hmm.
so far away from it, but you've seen people around you pass and you don't want to leave either a financial burden or whatever it may
Hmm.
be. And because of my own grandmother's funeral, I ended up planning my own funeral actually. Like, I
Mm.
pre-purchased so much. That, to me, that's pre-planning, right? Like, I have no anticipation of it, but I just want to get a peace of mind maybe for a future date. The second stage of end of life is active dying, which is fast forward to what we're kind of talking about with my other grandmother, which is, right, like, there's an anticipation now,
Hmm.
it's around the corner. Then there's just past, and this is the very topic we just moved from into. And then finally, there's after death, which is so ignored, right? The after death is 13 plus months and a lot more years of cleaning up someone's belonging, cleaning up, the physical part of it. But there's all these stored memories and like reliving of what could have happened, what I didn't do well, or yeah, that guilt. And that section, there's just so much that we can talk about. It's almost like equal amount of all three stages that's prior. That I would love to, have you on to talk a little bit more about in this very stage of just past, right? And the stats that we have, I think I have here, is that 31% of the families die at home, 30% die at a hospital, 21% at a nursing home, and 8% in hospice. But 70 to 80% Americans say they actually want to die at home, which is exactly what you said at the beginning of this episode, right? Yeah. Would love to ask two questions from that. One is, why is where we die still something that happens to us instead of a choice that we can make?
I think it's a great question and a great thing for us to ponder, because if most people would say this is what they would like, but that's not what the reality is, then what's happening? And I think of several things that are happening. One is that we don't always know when we're going to die. So if we knew today, we might make a different decision.
Mm,
But we don't know. So we don't know when we go to the hospital and end up in ICU, how many times do we know, oh, this is really the end? Because we're trying to not make it the end. And appropriately so, right? We don't want to leave some life unlived, if that would be good life if it's possible. And so, but sometimes we don't know until we get in there and we try and we see, and then we find out that it's not possible. And so I think part of it's the unknowability about when our end is going to come. And I think part of it is because we have a hard time talking about it in our culture and in the healthcare culture too. And so we end up in a place that nobody really wanted to be, and we're stuck. There's this beautiful myth that I'm not going to remember the name of the character in the myth, but it's one of those Greek myths where this man he asked the gods for his wish because he doesn't want to die. He wants to live forever. And so the gods talk about it and they grant his wish, but he doesn't ask for good health. And so his body breaks down, he suffers, but he cannot die. And it comes to the place that he would like to die, but he cannot. I think that sometimes it makes me think about our present situation some, where we can do so many things to keep bodies going, but does that mean because we can do it, is that really the best thing to do? And I think that in many cases it's not. It's not really helping
yeah.
somebody have a better life, and it's putting a burden of suffering on them. And then we have that idea that in some ways that it's shameful to die, that because you don't try hard enough, and people wrestle with that too. And I think a lot of it's connected to our general struggle with accepting the fact that we're limited and that we're mortal and that we'll all die.
Yeah, there's a quote that reminded me is it's not in the years you live, it's in the life you lived in those
Mm,
years. And that's absolutely brings me to tears because, my like I said, one of my best friends, I mean actually an ex-boyfriend to be complete now that we're acquainted, spent 72 hours just vibe coding and making the memorial. And it's just every time you look at the photos, you absolutely see, yes, he lived a short life, but I can't think about anyone that's not lived such a full life. And when people say full life, it truly is embodied in this person.
mhm,
And so same thing, is reflected on an elder person too, right? It's you live such a long life. Make sure that there is comfort and honoring of this person's wishes. And that's why this gap of 80% of what they wish for of die at home versus the reality of the split, right? And
mhm.
it's a reflection of a brokenness that potentially from the theme of this conversation is it's a lack of conversation, it's a lack of asking, it's, education and all of that. And so I guess my last question, Greg, for you is 30 years, thousands of families, the hardest room is truly in medicine or hospital. And if you had to leave everyone listening with just one sentence to carry into their own life, what would you say?
That's a big question. I remember when I worked in the oncology area, and I was talking with one of my nursing colleagues, and we were just talking about we'd had a tough run, and several patients that we really cared for had died, and we were talking about how do we keep on doing this? And the thought that came to me and that has stayed with me is that we need to practice being helpless, and because there's so many things we can't control, and the things we can't control we ought to try, but that's not generally the problem. The problem is not that we don't try to control what we can. The problem is that we're not very good at those situations that are outside of our control. And I found that the paradox, at least in the helping world, and I think this is for friends and for family and for professional caregivers like me, is that the more we're comfortable with being helpless and not being able to control the whole thing, the more helpful we end up being.
Absolutely. I'm getting goosebumps by you saying that. Thank you so much, Greg. I really
You're
appreciate your
welcome.
time. Thank you for all your wisdom and, your dedication and the 3 decades into what you do. And there's just so much to unpack, so much to learn. And my key takeaway is just inject humanity into a world where there's a lot of confusion and chaos, and
Hmm.
be there for each other, right? Be kind, leave your ego at the door. And oftentimes, when you get the news, all of those disagreements just completely dissipates. It's like, what was the point of it all, right? And
Hmm.
so, death is such a good reminder for the living to live to the fullest without boundaries and limitation, and just live like every single day.
Yeah.
Like it is your last. Truly, like I understand that quote now. I didn't really understand it before. So thank you again for the session. That was so beautiful, and I learned so much.
You're very welcome. Very welcome. Glad to do it. And thank you for the work you do. What you're doing and what so many other people are doing is such a good corrective and help for us, which is we could do a better job. And so let's see what we can do to make it better for people and not leave them struggling and without guidance and support.
Yeah, absolutely. Thank you so much, Greg, again. I really appreciate this.